In our third chapter of the endocrine section, we'll look at drugs used in hyperthyroidism. If we had hypo, we'd use literally the thyroid hormones themselves, so only anti-thyroid agents will be considered. In the table sites of action and effect, we on the left remind you of thyroid hormone synthesis and actions, and on the right show you the effects of anti-thyroid agents. Well, if we first look at the actual physiology, we know that thyroid hormone synthesis requires accumulation of iodide, the salt, into the gland. But then the salt has to be organified to iodine, and this is done by the enzyme peroxidase, which then in turn iodinates tyrosine residues of thyroglobulin. Tyrosine is actually iodinated in iodotyrosines, and then coupling reactions form diiodo or triiodo or tetraiodothyronines. It is proteolysis that will release a majority of T4, about 75% if you want, and a little bit of T3, about 25%, from thyroglobulin when needed. Now, T3 is the active thyroid hormone, so all the T4 that has been released must be converted to T3 through deiodination. This is done by a peripheral enzyme simply referred to as 5' deiodinase. Well, let's see where drugs work. Since the thyroid glands accumulates iodine, imagine you had a thyroid cancer and you wanted to destroy the thyroid gland. Then you could have selective cell destruction by giving radioactive iodine. Iodine-131 can be used for that matter. But that would be reserved literally for thyroid cancer. By the way, what's the most common thyroid cancer? I'm hoping you're saying in 80% of the cases it's the papillary carcinoma of the thyroid. You know, the one that we associate mainly with exposure to radiation, and of course the classic histology finding of psammoma bodies. It's a fairly good prognosis cancer. I mean, 20-year survival is close to 90%. You have long time and chances of dying of something else. But there are other thyroid cancers of relevance on your exam. You remember the medullary cancer that we see with multiple endocrine neoplasias? Don't forget the amyloidosis in this one. And you could think of things like the anaplastic thyroid carcinoma, which is really very severe in the elderly, encroaching quickly on the esophagus and the trachea and causing death rapidly. Now, as we look at rather hyperthyroidism, you know, a disease such as Graves' disease, the autoimmune disorder whereby autoantibody overstimulate TSH receptors. This is where we're going to use the famous group of drugs, thioamides. And thioamides, as our principal antithyroid agents, look what they do. They inhibit iodination, in other words, they inhibit the enzyme peroxidase. They inhibit the coupling reaction, and at high doses, they can inhibit the peripheral conversion of T4 to T3. Thioamides are the magic bullet in hyperthyroidism. Otherwise, I would attract your attention on the drug propranolol. As a beta blocker, it's always been of relevance in thyroid storms, thyrotoxicosis, or the exacerbation of hyperthyroidism. It's always been relevant with propranolol to decrease the excessive sympathetic activity. The choice of propranolol, though, is not gratuitous. It so happens that propranolol, as a beta blocker, is also a deiodinase inhibitor. So it truly is an antithyroid agent. Ipodate, iodide could also be used, but those are seldom seen nowadays in practice. This is why under the table we'll focus on thioamides. There are two thioamides. They're called PTU for propylthiouracil and methimazole. Now, their use is uncomplicated hyperthyroid condition such as Graves' disease. Generally, we consider that not only they inhibit iodination, but don't forget that high-dose PTU can also inhibit peripheral conversion of T4 to T3. Because they have thio in the name, they have sulfur, they can cause hypersensitivity. And the common hypersensitivity reaction is a rash, a maculopapular rash. Otherwise, both drugs are lipid-soluble and cross the placental barrier. So how do you choose which one to administer in pregnancy? I'm sure as we get to the end of our review tapes here that you're thinking high protein binding is the clue. And PTU is the one that is highly protein bound. Being highly protein bound, it's the one to choose in hyperthyroidism of pregnancy. If you were to use methimazole, the key issue is in crossing the placental barrier, it would cause fetal hypothyroidism. Iodide is generally administered as potassium iodide with iodine. It's called Lugol solution. Possibly it's used in thyrotoxicosis, certainly preoperatively, because it works much faster than PTU. It can already start decreasing gland size and vascularity. But it's never used long term, since after a couple weeks, normally the thyroid gland escapes the potassium iodide by decreasing its uptake.